I'm also I'm also an honorary research fellow at the University of York, where for many years I worked on methods around cost effectiveness analysis and incorporating inequality aspects into cost effectiveness analysis. So what I'm going to be talking about today is how that research has fed into some of the ways that NICE has started to look at quantitative ways of assessing health inequality impact. And the way I wanted to structure today was probably about half and half with regards to my two different hats. So I think the first half is a background to some of the theory around health inequalities and distributional cost effectiveness analysis, which has emerged as the main set of methods for evaluating health inequality impacts quantitatively. And then the second half, I wanted to go through how NICE has historically looked at health inequalities and some work that we undertook over the last couple of years to update some of its methods to reflect new types of analysis that can be conducted around health inequalities. Back to first principles, really. I want to go right back to the very beginning of how we get to a point of considering fairness and health inequalities in decision making. There are two main ways in which you could address concerns for justice in health resource allocation priority setting. First is procedural justice. So that's a case of making sure that all of your methods and processes are transparent and have accountable procedures underlying them. The second is substantive justice, which is about making sure that you've achieved the right decision. Just very, very briefly on procedural justice, because this is not going to be the focus of the talk, but I think a useful thing to understand about the way that NICE and quite a lot of other health technology assessment agencies operate is basing a lot of their approach to conducting their work and publicizing their work and their processes is underpinned by this accountability for reasonableness framework that was proposed by Norman Daniels a good while ago. And some of the features of it I've listed here. So the documentation of all of its methods and processes is publicly available, that decisions that are made by the organization are published and have the rationale provided, and that there's a capacity to appeal against decisions, all of which are features of the way that NICE operates. But as I said, that's not the main focus of what I wanted to talk about today. Substantive justice is the main focus, and there could be a lot of ways in which you might want to conduct quantitative analysis of the value for money of an intervention and the kinds of objectives that you might want to reflect in your decision making and pursue. One common one in the context of health is naturally to look at population health gain and to try and maximize the amount of population health. But then you also have other competing priorities that are socially important, and that could be giving some additional priority to those who have worse current health. And that's been reflected over the years in NICE's processes by the use of reflecting additional weight for people with severe conditions or those patients who are at the end of life. Another aspect you might be concerned about, those that are worse off in lifetime health, so not quite current health, but that's could be a moral argument that was made for fair innings, which is everyone should have a fair shot at having a some sort of minimum level of life expectancy. But another could be that because of the various social characteristics that people are born with or born into, that there might be health inequalities associated with those characteristics that reduce your chances of sort of leading a healthy life. And those are the kinds of concerns that I wanted to talk through today. What do we mean by health inequalities? So this is the official NHS definition, that health inequalities are systematic, unfair, and avoidable, and that they arise because of conditions in which we were born, live, work, and age. And these are the things that influence our opportunities for good mental and physical health. There are a myriad, so many different ways of defining health inequalities, and this is a point that I'm going to come back to with the way that organizations who want to promote health equality and reduce health inequalities have to kind of cope with. And some of the definitional questions, the three main ones are listed here. So that's equality of what? So we could be thinking here about directly about health outcomes. So things like life expectancy or healthy life expectancy. Could be healthcare related outcomes. So access to care, utilization of care. Financial protection is one that we'd see more in a global health setting, but is really, really important there. And the second question, equality between whom. So this is how we categorizing our health inequality in terms of the groups that we want to measure between. There are lots and lots of different important social characteristics that have been suggested and have been analysed in the literature. Socioeconomic status is the main one, I'd say, in the UK, but ethnicity is also a really, really vitally important one that is, I think, also of huge importance globally, particularly in developed nations. Geography, another one, divides between urban and rural populations. Excuse me, I do have a little bit of a cough, so I do apologise in advance. I've also listed the third question here, which is a technical question, and that is, how do you measure inequality? And there's a huge amount of literature that's been dedicated towards this. It could be anything as simple as a gap between two groups or a ratio, regression-based measures, or more complex types of functions that you can use that include lots of different arguments for how we weight all of the different groups. So a common one which kind of has been ported from the income inequality literature into the health inequality literature is based around the Gini coefficient, which is a common measure of income inequality that you might be familiar with. Here's an illustration of quite a famous study that was conducted in England. And this shows each dot represents about an area representing about 1,500 people, and each dot has a deprivation score associated with it. The most deprived groups areas are on the left, and the least deprived groups are on the right. And the two lines, we have the bottom set of dots, which is disability-free life expectancy, and then the top row of dots are life expectancy. And so disability-free life expectancy, just for those who aren't familiar with this, is if you live a year of your life with a limiting illness or a long-standing disability, then that year of life, your life expectancy, is excluded from your estimates. So it's a reflection of the health that you experience over your lifetime as well. And when we look at, so here, if we compare the most deprived fifth with the least deprived fifth, which are the two sets of circles that I've put alongside the curves, you see a difference in life expectancy of about 6 years and a difference in disability-free life expectancy of 12 disability-free life years. So what this illustrates is that you have inequalities in both mortality and morbidity, which won't come as a surprise, but is the extent of these is almost equivalent in terms of life years and those life years that are lived with disability. Almost doubles the estimate. So I want to fit this back in now to cost effectiveness analysis and the way that we evaluate medical interventions. And there's a theory that many of you have probably heard of, utilitarianism, first proposed by Jeremy Bentham back in the 18th century. This is a picture of him, actually. His mummified body is in the hallway at University College down in London. And his theory, utilitarianism, suggested that social welfare is a sum of individual utilities. And the way in which economic evaluation of healthcare technologies has been conducted over the past 40 odd years, by the most part, has been through cost effectiveness analysis. And that has been termed as something like called something equivalent to quali version of utilitarianism, in which the health-related welfare of a society is the sum of the health of the individuals in that population. But actually, in practice, and I think this is something that is probably intuitive to all of us, is that decision making in health is way more about just maximizing those benefits in terms of the raw sum of individual health. And it's more like something like this, which is you're summing across some function of not just individuals' health, but a bunch of other factors that are related, some of which related to fairness and equity, and plenty of other factors. So things like the innovation and of a particular intervention might be something that's of interest, and the unmet needs of that population is health related, but not explicitly their measured health. And in an organization like NICE, with the typical health technology assessment approach has been to lots and lots of quantitative analysis on the health component, and rightly so. It's the most really, really substantial and significant part of any health intervention's value is the health improving aspects of it. But there are also other important factors. Some of those fairness factors have been reflected quantitatively in NICE decision making. So I mentioned severity and severity weights as being one. That's something that's incorporated in a quantitative way in NICE's methods and elsewhere as well. And inequality and health inequality impacts, those haven't traditionally been considered in a quantitative way. And partly that's a data issue and partly that's a methods issue, but it's meant that it's been on a more deliberative level that's been reflected within economic evaluations and recommendations of new health technologies. So I just want to spend a few minutes illustrating exactly how this looks from a theoretical perspective. So here's your traditional cost effectiveness plane. You have effectiveness on the horizontal axis and cost on the vertical axis. So bottom right, you have things that are less costly, more effective. That's a win-win. Up in the left-hand top left is less effective and more costly. So that's no good. And then in these two other quadrants, we have the trade-off quadrants, where you're trading off between cost and effectiveness, and how you might trade off between cost and effectiveness is you might think about the opportunity cost of the health budget. So this is strictly within a cost effectiveness analysis, like theoretical framework. You have an opportunity cost of the health budget, and if something falls below that opportunity cost line, then the additional cost is worth the additional health that you've gained, and vice versa. So that's the way that you might sort of visualize the decision-making process of cost-effectiveness analysis. There's a corollary that we might look at for health inequalities, where you have net health is along the horizontal axis. So that's how cost-effective, like how much of an improvement in population health are you getting out of this technology, and then on the vertical axis is what's the impact on health inequalities. So top right here, you have something that's more equitable and more efficient. Bottom left, less equitable, less efficient. And then similarly, you have your trade-off quadrants here, where you're trading off between inequality benefits or reductions in inequality versus improvements in net health, and vice versa. So the difference here is that in cost effectiveness analysis, let me just go back, that this opportunity cost line is theoretically measurable. So you can have an understanding that, so opportunity cost, let me just go back here, is you're spending money on a new technology, and that's displacing money elsewhere in the health system, so you're not able to spend that money on other stuff, and so you're losing out on other potential benefit. And so that's what this line reflects, is how much benefit you might be losing out by spending your money on this instead of something else. That is technically a scientific question. When it comes to trade-offs between inequality and health, then that question is a social value question, because it's about how much you value health inequality reductions versus population health. and how you trade off between those two. And those social value judgments, I just got one or two slides here, which is just around some of how philosophy actually relates to real world decision making. That if you consider this example here, you have in this instance just two groups, 1 and 2, and they have baseline health estimates of H1 and H2, which you have here. And we have a health policy frontier. So we've got a bunch of extra money that we can then implement policies that could create any combination of outcomes between of H1 and H2 that sit on this curved line here. And the way that might translate is like this. So you could have the baseline health of H2 could increase to, I don't know if you can see my cursor, but basically the way that if we were to maximize the value of H1 plus H2, then it would be tangential to this line here. So it would give you this point where the curve touches this line, would be the maximization of H1 and H2 together. So that's the health maximizing thing. That's Bentham. John Rawls, who's another philosopher from the 20th century, one of his moral principles in the theory of justice was maximizing the minimum level of health. And so that would involve just maximizing the health of H1. So that would be his point here, would be just moving the frontier vertically up to improve the health of group 1. Any point in between these 2 points is kind of known as a prioritarian approach, which is that you're not doing the rules thing and maximizing the worst off, but you're not doing the Bentham thing, which is just maximizing overall health. You're giving some level of priority to worse off groups, but but exactly how much priority is the question. And just to finish on this theoretical introduction, evidence on social preferences around this and how prioritarian we really are is obviously it varies from society to society, but it can be captured in experimental evidence from discrete choice experiments. There's been quite a lot of these done in the UK and particularly in England. And the evidence from these discrete choice experiments shows that generally speaking, the public in the UK is willing to have some prioritarian leanings. They trade off some potential total health to have a reduction in health inequalities. But it's really murky. But not only is the experimental approaches liable to have biases, framing effects, anything that you'd normally associate with stated preference studies, but they vary by the social grouping. So whether you label your groups as being those like different socioeconomic groups, or if they're neutrally labeled, then preferences change, I think, based on the assumptions that respondents to these surveys have around the responsibility that certain groups might have for their own health, that kind of thing. It makes a difference in terms of how prioritarian we want to be. As I mentioned as well before, there's just so many different ways of categorizing health inequalities that this becomes a very, very complex problem very, very quickly. There is also, so the summary here is no consensus on the strength of preference. And lots and lots of studies disagree massively on this. Systematic review from a few years ago by Simon McNamara and colleagues showed quite a huge variation in exactly how prioritarian we actually are, and it depends on the group labels as well. Okay, so now I want to talk about distributional cost effectiveness analysis. So in short, this is a framework, an extension to cost effectiveness analysis that integrates inequality concerns. So it's you start off with your cost effectiveness analysis, and then you can potentially build on a distributional cost effectiveness analysis on top of it. And the first papers published about more than a decade ago, quite a lot of methodological and applied studies over the years have been produced, and it's just starting. I mean, nowadays you look in the health economic journals, and there's usually maybe 1 or 2 distributional cost effectiveness papers a month. It's becoming more common to see them around. In short, this is what it does. So I've labeled this slide distributional cost effectiveness analysis. This is just cost effectiveness analysis, really. This is rehashing what I mentioned earlier, which is that in cost effectiveness analysis, you have health benefit, you have the health opportunity cost, the health that you're giving up by spending your money on the new treatment. And then the difference between the health opportunity cost and health benefit is your net health benefit. And if that's positive, then in cost effectiveness analysis, then you have a cost effective treatment. And what distributional cost effectiveness analysis does is just break down these three components. So you look at differences in the health benefit, differences in the health opportunity cost, and then that gives you a distribution of net health benefit over social groups. I've got income groups labeled here, but it doesn't have to be income groups. It can be other socioeconomic characteristics. It could be ethnicity, etc. And so this is just giving you it's effectively like subgroup analysis in a way, but in terms of social characteristics rather than clinical characteristics. And what involves a few extra steps. So we don't just look at the recipients of technology and intervention, because when you're talking about resource allocation within the health system as a whole, it involves patients that are affected by the opportunity costs as well. So that's outside of the intervention group, and that the effects on those groups as well need to be modelled. And because we're thinking about health inequality at a population level, that we need population sizes as well. So there's some extra data requirements associated with distributional cost effectiveness analysis. Here's a useful way of conceptualizing how we might go about modeling the health inequality impact, and that this is I think variously been called things like the inequality staircase, where you look at the different stages of disease and treatment, and you can model the inequalities at the individual steps and combine those together to give an overall picture of what the health inequality impact is. So you start off with differences in disease prevalence, how many people are receiving the intervention from that eligible population, whether there's differences in terms of the effectiveness of the intervention. Do some groups benefit more? And then the longer term health benefits, so things like mortality and their quality of life going forward. Just to give that a bit more weight behind it, let's consider a smoking cessation intervention. For disease prevalence, lower income groups have a much higher smoking prevalence. In the UK, I imagine those trends are fairly common across countries. So much higher prevalence of smoking. But when you're talking about interventions to quit smoking, high income groups are much better at seeking out the help. And then once they seek out the help, they're actually more likely to succeed in quitting. This is from this example is one of an early distributional cost effectiveness model that I was involved with. That the high income groups have a higher quit success rate, and then they also have lower background mortality. And so, excuse me, when you put all this stuff together, you get the overall picture of what health inequality impact looks like. And just to talk you through what the many dots on this graph show is that each row of points is a different intervention. But it shows that if you just looked at the prevalence inequality on its own, then you get the dots, the blue squares on the right. So the inequality reduction is much higher if you only look at the prevalence of the differences in prevalence, inequalities in prevalence. So that's where you have these large inequalities in smoking prevalence. So when you only model differences in prevalence, then you have the low income groups, the low socioeconomic groups benefit lots more than the high income groups, because they're all getting the intervention. But when you start modeling the utilization as well, utilization inequalities, then the inequality reduction starts to decrease because as I just mentioned, that low income groups are less good at utilizing smoking cessation services. And then when you model all of the staircase that I just showed, then you have the red circles on the left. So it basically just shows the importance of modeling across the inequality pathway. the treatment pathway and all those different inequalities to get your true inequality impact effect. Just a quick word as well on opportunity costs and costs. So this is an example of conceptually what I mean around health inequality, health opportunity costs, and the distribution of health opportunity costs between different groups. So consider the large rectangle as our health budget, and then we have a new program that we want to fund that's going to cost $20 million. The benefits of that are the health benefits that we can model and do the subgroup analysis of, and we can see that, okay, for this technology, this disease population, and this intervention, the more deprived groups can have this level of benefit. So we can model that distribution of benefit. But then we also have these $20 million of foregone services that are now being used to fund this new technology. And we want to reflect the fact that those foregone services also have a distribution between these types of groups. So there'll be high income patients in this population, low income patients in this population, and figuring out exactly how the distribution of those opportunity costs is. It's a really, really difficult methodological problem. There's been a few papers that have looked at it here in the UK with some variable results. But it's an essential part of distributional cost effectiveness analysis, because it's built into the way in which the analysis is done that some assumption around how opportunity costs are distributed between groups has to be made, which is right, because that in real world decision making, those are the trade-offs. And just to illustrate exactly how important the distribution of health opportunity costs are, I've put together this table. So we've got our three groups, A, B, and C, and the benefit of the intervention is more heavily weighted in terms of Group A. So Group A benefit with 8 QALYs, Group C benefit with 6 QALYs, Group B are in between with 7. It's cost effective because the benefits outweigh the health opportunity costs, as you can see. So we have, what would that be, 21 QALYs in the benefits and 12 QALYs in the health opportunity costs. That's 12 across all of the groups. We don't know how they're distributed yet. So if we do one scenario where we say they're equally distributed across all of these three groups, then so that's 4 QALYs as health opportunity cost for each group. Then the net health benefit, you have 4 in Group A, 3 in Group B, 2 in Group C. But if we do a different scenario in which actually Group A, they benefit the most, but they also incur a greater share of the health opportunity costs, and they're distributed as such, so that you'd have 6 QALYs as the health opportunity cost for Group A, 4 for Group B, and 2 for Group C. But then you end up, the net health benefit distribution is reversed. So you end up with C benefiting the most and A benefiting the least. And you can imagine that if Group A is a low income group or a high deprivation group, then you've gone from reducing health inequality to increasing health inequality. So it's obviously a very significant input. Just a quick word on outputs before I finish on this primer for DCA, is that you basically would present plots and tables showing these 3 different components: the health benefit, the health opportunity costs, and the net health benefit distributions. An example of that is shown in this plot here. You might also plot some inequality metrics. So I mentioned it a little bit at the start. You might have gaps or ratios. You might have the slope index of inequality, which is a regression-based measure. There are more complex measures, ones that, as I'll come on to, NICE hasn't looked to adopt. But they are available, and they are often included in distributional cost effectiveness analysis studies. Right, so I'm going to finish now. I've got a few slides left here to talk about health inequalities at NICE. First thing to say about this is that NICE, as I come on to, it has underlying objectives and principles that relate to health inequalities. And outside of any kind of quantitative assessment, that there are still plenty of things that NICE does to help support and address health inequalities in the UK health system and in England primarily. And that includes things like NICE just provides guidance in areas where there's really significant and important health inequalities. So it produces guidance on areas to things like smoking, alcohol use, physical activity, behaviors that are big drivers of health inequalities, and where having good guidance can help address those health inequalities, particularly in making solid recommendations to practitioners. We also have this thing in England called Core 20+5, which is where the NHS has set a strategy for addressing health inequalities, and it identifies key clinical areas and population groups that are affected by health inequalities, and NICE has provided quite a lot of guidance around that. So includes things like asthma, diabetes, severe mental illness, maternity-based interventions. So things that have, again, linked to key drivers of health inequalities where important recommendations have been made. Also, it's really a lesser known feature of NICE's work is its topic prioritization. So basically, there's more technologies and interventions than NICE can look at. That's probably not a surprise, but one that NICE has to deal with in terms of prioritizing which topics it looks at out of all of the potential candidates. And it has a transparent and explicit topic prioritization process. And that includes consideration of health inequalities. So when a topic is its potential value is being considered, health inequalities is one of the aspects that are considered. So again, just feeding into that idea that the guidance that NICE is producing is also intrinsically feeding into areas where health inequalities might be present and can be addressed. NICE has also looked at it has a deliberative engagement arm. It's almost like, I suppose, it used to be Citizens Council was what it was called, where there was a standing panel of public advisors, effectively, who would think about important social value topics that NICE was engaging with, and would advise NICE with in terms of its principles and social values. And that has been replaced over time with this program called NICE Listens, where we go from topic to topic and convene in this. Nowadays, it's different panels for each topic, but one of them was around health inequalities, and I think echoes some of the points that I was making earlier around the literature that's looked at social preferences around health inequalities. But a couple of interesting additional ones, which I think probably ring true for many people who work in this area, and that's the health system is just one of many levers for tackling inequalities. There might be health inequalities, but the health system is not always the best place to address them. The best place to address them might be, in some instances, it could be as simple as income redistribution, educational policy. It can be done in an enormous number of ways due to the relationships between social conditions and income and health. The fact that there's a lot of dynamic relationships that determine health. The second one is one that will be familiar to us all now, which is that there's a general agreement that inequality reduction is a priority, but exactly how big this trade-off should be is something that, as it is an issue of social value, has a lot of disagreement over it. And the last is another interesting point for me, which is the implementation of interventions is one of the aspects that drives health inequalities more than others. And I think this does ring true, that just recommending interventions that can potentially reduce health inequalities is half the battle. The other is actually implementing in the way that reaches the people that they need to reach. This slide is a primer really on the amazing scope of NICE's work, which I think for many people they might think about these two things, which is technology appraisals, which is the evaluation of medicines, new medicines. So a new pharmaceutical comes into the market, and NICE does a value for money assessment and either recommends it or says that it's not good value for money. The other part that I think is most that NICE is most famous for is its clinical guidelines. So this is guidelines for healthcare practitioners in the UK of best practice that incorporates all of the best value for money interventions and guidance, so can recommend across the whole pathway. In reality, NICE has a huge scope that includes all of these other types of technologies. So highly specialized technologies, for example, is orphan drugs for technologies that target diseases with very, very small populations, diagnostics, medical devices, all sorts of different areas. And each of these has different remits. So some might just say yes or no to technology. Others might be able to make recommendations on implementation and wider parts of the pathway. Just wanted to say a little bit about technology evaluation. So this is the medicines and new medicines evaluation. So health inequalities issues could be identified at the start of an evaluation process. So the scope of the evaluation determines what can be considered by the committee, and health inequalities can be identified there. And then stakeholders and experts can identify health inequalities issues in their committee meetings. And the committees themselves are allowed to incorporate social value judgments based on both NICE listens, which we just covered, and NICE principles. And there is an explicit NICE principle, Principle 9, which is around reducing health inequalities. So there's a key through line throughout the technology evaluation process that allows health inequalities to be considered. Guidelines is the other one that I mentioned. This is an extremely busy slide. Don't read any of it. Just note that the green circles in the middle represent the different steps of a guideline production process, and the blue boxes represent all the ways in which health inequalities can be considered across the process. And basically what this slide shows is that throughout the process of developing a guideline, there are steps at almost at every point to reflect whether there's a health inequality concern that's of importance and that should be considered by the committee or included in a quality standard or highlighted for implementation when it goes out to the actual healthcare practitioners. And within the guidelines program, there's also been some minimal piloting of distributional cost effectiveness analysis, just to see how that evidence is considered by the committees, whether they find it useful. That's been done in a couple of guidelines around weight management and I think diabetes as well. That's used an online tool, which if I do have time to show you, I will, which is kind of an automated tool for conducting DCA, which is I can certainly share the link, and you can, anyone who's interested can have a look at it. But what we did over the last couple of years, which is what I mentioned first before, was that the evidence base around DCA has been maturing over the last 10 years. And so we've had that methods development, the evidence production has started to ramp up in terms of an understanding of what the relevant evidence is and how it can be produced. And that meant that it felt like an appropriate time for NICE to weigh in on this and to reflect it in some of its methods. And that resulted in what we call a modular update, which is NICE has this big methods manual, and a modular update is just adding in a bit of extra content to that manual to reflect a change in methods and process. And for this, it was the allowance of certain quantitative health inequality analysis. So what we added for the modular update, we defined what type of relevant health inequalities evidence would be useful. So DCA synthesizes lots of evidence. I showed that staircase of inequality, and the different steps of that staircase are all require different types of evidence, and providing some guidance on what that evidence should look like, namely that it should be from good quality national data sets, either hospital or primary care, and include certain types of stratification of deprivation level or ethnicity. The second part was appropriate methods and assumptions. So this has been summarized in a methods support document that we've published online. So this is basically outlines good practice for conducting a DCA. So how to stratify your population, what kind of scenarios you should look at in terms of your health opportunity cost distribution, and certain other bits of best practice that we wanted to find. And then the last thing was impact on decision making. So this is a really interesting area for people who work within NICE, which is that we have a cost effectiveness threshold that is used to determine whether an intervention represents good value for money or not. And if there's a case for there being really, really substantial health inequality benefits from an intervention, that the committees have always been able to and can continue to be able to have flexibility around that decision threshold. So they'll actually be able to reflect that trade-off between inequality benefit and population benefit in their decision making. I think one important thing to note is that this is not what we didn't end up advocating for explicit quantitative weights around inequality consideration. So it's not the case that if an intervention benefits this group by X amount, that then we'd be willing to pay this much more for it. There's too much complexity and variability in terms of the different ways in which health inequalities can arise, that it meant that NICE evaluations would require so many different sets of weights to cover so many different circumstances that it's not feasible, practical, or desirable for committees as well to have that level of complexity. And so some of these like formal quantitative approaches for estimating health inequality impacts, they have not been adopted, and the committees have discretion to look at the DCA evidence and kind of make the decision on their own. Okay, I've got 15 minutes, so I think I can just go through these examples quickly. So this is a couple of examples of where health inequalities were considered to be relevant by committees, and this was for a pair of appraisals that were conducted for a single drug. So it's called Exocel for short. It's a very long, complicated name, but for two conditions, beta thalassemia and sickle cell disease. So for both of these conditions, that the company put forward in its submission to NICE that there were these substantial inequalities. They were by ethnic background, but they produced their distributional cost effectiveness analysis by deprivation level. And they'd conducted some prevalence studies that I can show the results of here, where you have much larger proportions of the population sit in the most deprived groups. For sickle cell disease, this is probably about as bigger gradient as you'll see across deprivation groups for a disease. But for beta thalassemia, there was also additional qualitative information that was submitted. So the treatment could significantly reduce the need for transfusions, and transfusions were associated with quite a lot of inequalities because there were not only reduced availability of donors for some ethnic groups, but the amount of time and effort that it took for to actually interact with the healthcare system exacerbated the inequalities in access. Excuse me. So those are an example of just a couple of examples where health inequalities were considered relevant, and some of the quantitative analysis that supported it. I do have time, I think, just to, before we take any questions, if you do have any, to just go through this app. So I can share this link. It's a shiny app where you can conduct DCA evidence, produce DCA evidence. So you might have, so you'd start off by defining your disease population. So, I mean, here we can type sickle cell, and it uses data, very outdated data, I should say, from England, hospital data from around nearly 15 years ago now, 2011, 2012. and but it's kind of a proof of concept kind of study. So you type in your disease area, and you can define your age range. Then you add in your cost effectiveness information. So you might have, say, we generate half a QALY per recipient, and it costs £10,000 per recipient. It uses that hospital data from the disease population to populate the distribution of your eligible population. You can change this if you want, so you can adjust it if you have different data and better data potentially. So what you can see here is, again, I like the example that I showed, that for sickle cell disease, there's a huge concentration in the most deprived groups in England. You can also model the uptake rates between all the different groups. So these are automatically set at 100%. So all of the eligible patients receive them, but that can be adjusted. And then you can also adjust whether certain groups benefit more than others from the intervention. And then lastly, you have the health opportunity cost. So here you have how costs are converted into health opportunity costs. So this is how productive your health system is effectively. And then the distribution across the groups in terms of where the opportunity costs fall across in this instance, deprivation groups. And then you can simply run the scenario, and it shows you a whole different range of plots. So this is the one that we were most interested in, which is net health benefit. Here you can see that you have an actual negative net health benefit across the whole group. That is because you have a threshold of £15,000 per QALY, but the intervention has an ISA of £20,000 per QALY. So this is the ISA is above the threshold, so that suggests that the intervention is not cost effective, but that can change. So if we were to put the cost down to 5,000 and reran the scenario, that you'd have overall a positive net health benefit across all of the groups. Yeah, so I can share this tool. It's more of a teaching and learning tool, but definitely useful for anyone who has an interest in playing around with some of these methods. And that concludes my talk. So thank you very much.